Welcome to Season 4 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Josh Sharfstein, Vice Dean for Public Health Practice and Community Engagement and a former Commissioner of Health in Baltimore City. Our goal is to bring scientific evidence and experience to current topics in public health through engaging interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Today, I speak with the Health Commissioner of the state of Mississippi, Dr. Thomas Dobbs. Dr. Dobbs is an infectious disease physician who has steered his state through one of the most difficult COVID summaries in the country. Let's listen. Dr. Dobbs, thank you so much for joining me on the podcast. What is the COVID situation right now in the state of Mississippi?
The COVID situation is still pretty bad. We're recording over 2,000, 2,500 cases a day. But as bad as that is, it's not as bad as it has been. We had really just a phenomenally bad month of August. The Delta surge really swept through us in an aggressive way. And really, if you look at the impact on our healthcare system, and the number of lives lost, it's really been traumatic.
How many people died in August?
We lost over 1,000 people in the month of August alone. And a lot of those folks were, younger age groups. Just this last week, when we looked at the number of deaths that we've had, about 50% of them were under the age of 60.
That's incredible. And I can say that we saw some of the images of intensive care units spilling over and hospitals creating wards outside. What had to happen to take care of all those patients?
It was phenomenally stressful. And I really wouldn't have anticipated that we could have had as much stress on the healthcare system as we had. The winter surge was really pretty remarkable. But going into the Delta surge, going into August, we really pushed it to the limit and then some. We learned from the previous surges, and I think that helped. But basically what we did is we converted most of our ERs into ICUs. And at some points, we were negative 50, negative 60 ICU beds across the state or more, actually, that's just for COVID. Actually, even today, we're about negative 100 ICU beds because we're bedding ICU patients in the ER. A lot of the hospitals have converted their operatory suites, their endoscopy suites into accessory ICU rooms. So it's really been a phenomenal expansion of capacity. And the healthcare teams, the ICU nurses and docs have been phenomenal. Fortunately, I think we're just going to kind of just barely skate through without having to do any of these really sort of terrifying crisis standards of care decision-making processes. But it's been really, really difficult.
What is the role of the state health department in a situation like that when there really aren't any beds? What do you do to try to match whatever supply you have against the need?
There's several things that have to happen. And fortunately, I think there was such a general recognition that more dramatic steps had to be taken. We mandated that elective surgeries that required overnight hospitalizations, that those stopped for a period of time. And we know that adds dozens of ICU bed capacity in addition to a lot of floor capacity. We also set this thing called a mandatory system of care, where the Department of Health with our partners at the University of Mississippi Medical Center and our bed control system, MedCom, that does like the trauma system, took over all transfers. So any ICU transfer had to go through MedCom. And that way, we made sure we did proper load balancing and all the hospitals were full, right? So normally a hospital say, I'm full, I can't take anymore. But under this sort of system of care plan, we just say, there is no full, right? If you're up, you're up and you take another patient. And if you have to stick them in the hallway or put them in the ER or wherever, they're yours. And we just to help balance it out. And, usually hospitals can take one more. They can't take 5 more. They can't take 10 more. And this helped us sort of balance it out over time. And I think it was remarkably successful.
What is that like for you to be making calls to hospital leadership, telling them that basically you're turning their model upside down? They can't take care of the patients they usually take care of. You're going to be telling them who they are going to be taking care of. What's that like for you, and how does that go?
It's not as hard as you would think, because how it's kind of played out is we've tried to maintain really close communications, and we have a pan hospital call every Friday morning, kind of going over the state of affairs and getting feedback. And to be honest, we monitored the situation. We let them know this might be coming, and then at some point, some of the hospitals were at a critical point that they were afraid of the negative consequences for their patients that they were asking for us to do it. And once we started having people say, hey, this is out of control, you have to take over this situation, then we do. And once it was that point, we had, really, really no complaints. I think the elective surgery thing was a little bit tougher because I know that's a profit thing for them, but there's also patients who, and a TAVR or some heart procedures, they're elective technically, but they're urgent. And so there's also sort of a medical health issue too. So we don't want to do that too long. But for the system of care plan, we've had a lot of support.
That's good. Now you have not only these, tents in the parking lot getting set up and all these extraordinary measures, but as you said, you've seen a lot of younger patients. And I know that you have been doing some communications about the effects of COVID on pregnant women and fetuses. Could you talk about that work in the middle of all this?
And that's one of the things that's been really hard for people to not realize is the dangers that COVID has for pregnant women. Women who are pregnant are at high risk for complications from COVID. Now, throughout the pandemic, we've seen some severe outcomes and some deaths. But with the Delta surge, it actually has been a lot more intense. And I think that we have a sense, and I think it's starting to bear out a little bit, that the Delta variant is worse on an individual basis in some levels. I think that data is starting to evolve. And I think on an anecdotal framework, people have been telling us that for a long time. We have lost 15 moms throughout the course of the pandemic, but 8 of them have been within the past 7 weeks. So kind of correlating with Delta. And they're dramatic. It's terrifying. It's mostly second, early third trimester moms. And we're seeing situations where the docs are telling us, they're having to race up to the ICU and do an emergency C-section in the ICU before the mom dies so that the baby can have a chance out. And we're talking like 24, 25 weeks, really early preterm, just dramatic tragedy just all around. And then, not a one fully vaccinated. I think of the deaths we've had, of the 15 deaths, 14 were totally unvaccinated and 1 was only partially vaccinated.
Wow. And you've also calculated high rates of fetal loss.
We have identified 72 intrauterine fetal demise after 20 weeks, which is a lot. It's really twice or more than the background rate we normally see. So, we do know from other studies that COVID has an adverse impact on pregnancy outcomes and, for the mom, but also too for the baby. So I don't think it's surprising, but to see the doubling of the rate and that many losses is really painful.
And I saw that Mississippi recently got to the top of the list in the number of deaths per capita. Is that right?
Yes, we anticipated that likely was going to happen. So Mississippi per capita is the number 1 leader in deaths, and we're still going up. So I think we just passed New Jersey, and I think we're gonna spread the lead up even by more. So hopefully, as we get through the Delta surge and as folks are starting to realize the dangers, we've had a pretty good uptick in our immunizations. So we're not last in the country in immunizations anymore, but still that lack of immunity in the population, and especially the lack of vaccination, especially within sort of our 50 and younger age groups, has really been devastating. And that's why, if we look at what happened in the nursing homes, we've had very few deaths in the nursing homes during the Delta surge, which is phenomenal. But it's because they're 85+% vaccinated, right, in the nursing homes. But if we look at the rest of the population, which is going to be a lot lower, especially in that sort of 25 to 50 age group, we've seen a lot of deaths. And my wife runs an ICU in a community hospital, and she's like, this is something we've never seen before. We're having to sit down and talk to wives and elementary school kids because their dad's not going to make it home or their mom's not going to make it home. I mean, just really the magnitude of the personal tragedy is absolutely shocking. And the impact not only on the families, but the healthcare workers who are having to go through that sort of traumatized experience over and over again, it's hard to overstate.
I'm going to ask you a question I don't think there's an easy answer for, but why do you think it's been so severe in Mississippi? What do you think is behind the scale of the suffering that you're talking about?
Well, there's a lot of things wrapped up in that. Mississippi has a lot of challenges. At the core level, it's a lack of underlying immunity, right? If we're just talking about it, we don't have enough folks immune. And the main reason is we don't have enough folks who are vaccinated. And that's a complex question because, there's different elements of our society. Some folks are distrustful of government for different reasons. Some of it's going to be because of historical inequities, right? And distrust, or some of it's just going to be, general distrust of the government. Well, and a lot of it's people thinking, hey, this is not for me, right? The vaccine, I'm not worried about getting it and dying. And I think people have learned that lesson the hard way. But additionally, there's a whole media environment and social media environment that undermines good public health recommendations and science. And sometimes if that's the world that you live in, that's more potent than the good advice that you get there. But also, we also have a lot of other problems in Mississippi. We have a high rate of obesity, diabetes, risk factors that increase your rate of adverse outcomes. And then, access to care. We have a lot of folks who are uninsured. So there's a complicated list of things that go into this together. Vaccines are broadly available. It's not an access issue, except for maybe rare circumstances. I mean, we will bring a vaccine to your home. I mean, we will do anything we can to get you vaccinated, but it's just the choice to be vaccinated, getting folks to that point.
It sounds a bit like what you're saying is that it's not that people don't want to do the right thing for their health. They may be actually confused about what that right thing to do is.
I think you're exactly right. I think a lot of folks don't know the right thing to do, and getting the proper health education messaging or also risk assessment. I mean, I think that's a big problem in Mississippi from a preventive health sort of normal process is, we're under vaccinated for HPV and we are, behind on colon cancer and breast cancer. I think preventive stuff for a lot of the population is under accessed just because of a whole host of reasons. But then again, for even people who understand their risk, the things that they are embracing as usable information in many ways is just absolutely false.
If I could give you a magic wand where you could, or some sort of special device that you could summon a dream team of communicators, to help reach people in Mississippi who've been so reluctant to get vaccinated, who would you put on that team? And I guess what I mean is, probably not it's just the health officer and the deputy health officer and the assistant health officer. It's, who are the people that would be great to be, pulled together and speaking out and reaching people? Do you have a sense of, what might help in that regard?
I think a lot of local teams who have deep roots in the communities where people are becoming confused or misled is going to be in the church, especially even like the predominantly white churches. There's a lot of miscommunication and misinformation happening there. It's going to be in, those Facebook circles, people that they see at the ball game or, run into a Kroger or whatever, penetrating those local networks. We talk about sometimes public health grassroots really being where things change. If you want to make a difference in a community, you got to start at the grassroots. And it's what we've seen is grassroots miscommunication works extremely well. It thrives and is very successful. But grassroots, science-based public health messaging is harder to establish. It's harder to make it work. And so I think penetrating those networks is what we'd have to do. And, I would rather have 1,000 local people who are connected to their communities than the entire roster of the NFL, right? I mean, it's the people who you're interacting with every day. If we think about what influences people's decisions, a lot of it is personal self-interest, but then also too, what is the normative behavior of your peer group? And if we can help penetrate that normative behavior of the peer group on the local level, I think we'd be more impactful.
It's a great insight. Do you think that the challenges that Mississippi has faced over the last few weeks have been, helping to penetrate that? Do you see churches or local leaders kind of flipping on vaccination a little bit, or coming around, or encouraging it now? Is there anything about this just scale of the problem that Mississippi has had that makes that task easier?
There are some things that have helped, and I do think some folks have sort of shifted their roles in being advocates. But I think, to be quite honest, what's really driven some of our increases in vaccinations and behavior change is fear. It's people realize this personally could affect me or my family. Or it's, I cannot believe that my cousin who was 45 and ran a marathon every month is now dead of COVID. Sadly, I think those realizations are getting people to acknowledge the real risks, especially when we have like a small, noisy, sort of misguided group of people that punch above their weight, as far as saying, COVID's not real, and then COVID's not bad. And then now the new sort of false narrative is COVID's inevitable, so don't even try. I don't know what the next one's going to be. There's a sequence that we see it sort of evolve through. But yeah, it's tough.
So I did hear that you have a pretty high rate of protections for kids in schools in Mississippi.
We have found some avenues for success, and one of them has sort of surprisingly been some of our school infection control policies. We have a system in Mississippi where the local school districts make the decisions on what their policies are. We have state-based guidances that are based on the CDC, best practices, especially involving masks in the classroom. And we know that's been a real contentious issue. We do have a monitoring system for cases, quarantine, all that kind of stuff. And early on, a minority of school districts were doing masks, masks. We do recommend that, obviously. But as the school districts have seen the challenges staying open, as they have had to close down because of mass quarantines or cases or too many teachers, 86% of the schools that we have polled have universal masking in the classroom. And we have seen a plummeting in our average daily case load for students. And so, I think the evidence behind masks is so overwhelmingly apparent now. I think it was pretty apparent before, but now it's just like a mountain. I think, unfortunately, somebody else's evidence doesn't work. You got to have your own evidence. And I think we've had a lot of experiential learning in our school systems.
Well, that's good. Well, as you look ahead, what are your priorities for the pandemic in Mississippi?
Continuing to get folks who are unvaccinated or non-immune to get vaccinated. I think that's going to be critical. Looking at children, we still have the biggest subset of our population that's not immune is going to be our sort of school-age kids and young adults. So really looking at that. But then at the other end of the spectrum, really looking at our vulnerable folks. 98% of our new cases are unvaccinated, but only about 86% of our deaths are unvaccinated. That still means that this 14% of our deaths are vaccinated. And who are those folks? They're older folks. They're almost entirely over 65. They have weakened immune systems because of chronic medical issues. And I think looking forward to making sure that the third doses and the booster doses are available for the appropriate subsets of the population. We know FDA and CDC will probably give us some guidance on that by next week. And getting really ready to outreach and get to those vulnerable populations is going to be critically important.
Got it. Well, I know how hard you've been working on this and how difficult it's been personally, because every single health officer around the country working on this is getting, criticized and attacked in different ways. And you have seen your state to the brink of healthcare system failure, and now you're coming back from the brink, which is itself, under the circumstances, an incredible accomplishment. How do you find the strength to just keep pushing forward in this pandemic where at the end, we don't know whether it's in sight yet?
Boy, that's good. I think you get used to anything, right? So, but also having a good team is so important. We've got a phenomenal public health team. I think, through the pandemic and the motivation of good people who want to fulfill the purpose of helping Mississippi get through the pandemic, we've actually built a stronger public health team. And with everybody having their role, it becomes almost like a fine-tuned machine where things can happen more sort of spontaneously in the reaction because you have that team in place. So that's absolutely critical. It's actually a lot easier now, oddly, even though it's worse in some respects than it was back in March of 2020 when we didn't have the strength of our teams established. And there was a lot more undeflectable anxiety and anger coming to a small number of people. But now we have the networks like, we have an answer for that. We have this program in place. We have the homebound vaccination plan. We have our network of monoclonal providers. We have our, 500, members of our sort of like community vaccination teams. So having those structures built up makes it a lot better, right? And it just becomes normal.
I know you have a big effort focused on equity in Mississippi too.
Yeah, and we absolutely do not need to forget about that in all of our efforts. We've been relatively successful in that actually vaccination in African Americans is disproportionately high to the population, just by a little bit. But still, I think it speaks part of some things. I mean, in ways we're sort of under-vaccinated in all populations, right? But at least we're equitably failing, I guess, if you want to put it that way. But yeah, no, we got a strong health equity team. We've been being a lot more engaging with our with our immigrant population and our Latinx community, which has been good. And I'm hoping we can actually had a meeting with some of my staff today, but how do we parlay that into health gains in other areas, maternal child health, chronic disease prevention, cancer prevention, those sorts of things. So there are opportunities hidden within the challenges we've seen.
Well, that's a good point to end on. Thank you for everything that you're doing, Dr. Dobbs, and really appreciate your spending some time with us.
Thanks, Dr. Sharfstein.
Public Health On Call is produced by Josh Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by Spencer Greer, Niall Owen McCusker, Cian Oates, and Matthew Martin with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo and Neiman Outland. Social media support from Brenda Haggader, Grace Holes Fernandez, and Caroline Wong. Thank you for listening.